These are the different respiratory disorders that I will discuss. So let us go over them one by one. First is choanal atresia. It's the congenital obstruction of the posterior nares, which is either unilateral or bilateral, preventing newborn from drawing air through the nose down to the nasopharynx. Newborns up to approximately 3 months of age are naturally nose breathers. So if they have choanal atresia, they develop signs of respiratory distress at birth or immediately after they quiet for the first time and attempt to breathe through their nose. It is usually caused by an obstructing membrane, which is usually soft, or a bony growth that is hard. Assessment and diagnosis. First, a way to do it is to hold newborn's mouth close, gently compress the first nostril, then the second. If atresia is present, the child will struggle as he or she experiences air hunger when the mouth is closed. Their color improves when they open their mouth, especially sometimes when they cry. Second is passing a catheter into the nares down the stomach. Passing a soft number 8 or 10 French catheter will do it. If it will not pass either bilaterally or unilaterally, the diagnosis of choanal atresia is confirmed. Problems are usually focused on airway and feeding. Airway, as infants struggle to breathe in through the nose as they are nose breathers. Feeding because they become cyanotic whenever they feed because they cannot suck and breathe through the mouth simultaneously. For management, they must be started on IV fluid to maintain glucose because of the feeding problem. This is done until surgery can be performed. Second is to insert an oral airway so that they can continue to breathe through their mouth. And last is definitive treatment, which is surgery through local piercing if it is a membrane or surgical removal of the bony growth. Next are the different upper respiratory tract infections. First is acute nasopharyngitis, or commonly known as the common cold. It has 2 to 3 days of incubation period. When you say incubation period, the pathogen entered your body, it grew and multiplied, and you develop symptoms. Frequency. Toddlers usually have an average of 10 to 12 colds a year, while for older children, average of 4 to 5 yearly. Acute nasopharyngitis is commonly caused by viruses, which are listed in the slide. Assessment findings, nasal congestion. There could be watery rhinitis with sore throat, especially if the infection is in the posterior part. There's low-grade fever or sometimes none at all. There could be an inflamed nasal mucous membranes, which can sometimes lead to congestion. There's difficulty breathing. There's cough, because any kind of infection in the respiratory tract can trigger increased mucus production. There is also swollen or painful cervical lymph nodes. And if the infection is caused by a bacteria, we can easily differentiate because of the thick, purulent nasal discharge, which is usually greenish to yellowish in color. For infants, because these younger children tend to respond to illnesses or infections systemically, they could have a high-grade fever of about 38.8 to 40 degrees Celsius. GI tract may also be affected. with vomiting and diarrhea, and sometimes they refuse feeding. There is poor appetite. Therapeutic management. Antibiotics are generally not effective unless the causative agent is a bacteria. If yes, it must be administered in 7 days. Acetaminophen or Tylenol can control fever. To liquefy nasal secretions, saline nose drops and vaporizers can be given. Phenylephrine nose drops can also constrict nasal mucous membrane, freeing the airway. This is for congestion. And suctioning nasal mucus can also be done, especially if the coughing is not enough. Pharyngitis is infection and inflammation of the throat, which is often painful. It can be described as sore throat. Its peak incidence occurs between 4 to 7 years age, and it could be either viral, bacterial, or a chronic allergy in which there is constant postnasal discharge resulting in secondary irritation. At least a slight pharyngitis usually accompanies all common upper respiratory infections. There are 2 types of pharyngitis, viral and bacterial. In viral pharyngitis, causative agent is usually adenovirus. The symptoms are generally mild, sore throat, fever, general malaise. On physical exam, there's an enlarged general lymph nodes. There's also erythema at the back of the pharynx and palatine arch, and the laboratory studies indicate that there is increased WBC. If the inflammation is mild, children rarely need more than an oral analgesic. You can give acetaminophen or ibuprofen for comfort. Also, encourage to gargle warm water to reduce pain. School-aged children are capable of doing this, but for younger children, you can apply warm heat to external neck to soothe the area. You can use a warm towel. And number 4, ensure sufficient fluid as they prefer liquid than solid foods. This is because children's throats feel so sore. Bacterial pharyngitis, on the other hand, is caused by group A beta hemolytic streptococcus. It must be taken seriously as they can lead to cardiac and kidney damage from the accompanying autoimmune process. If cardiac, it can lead to rheumatic fever. If kidney damage occurs, it can lead to glomerulonephritis. Assessment findings. Streptococcal infections are generally more severe than viral infections. You can compare the difference between these findings with that of the viral. Management. A full 10-day course of an oral antibiotic such as Pen-G or clindamycin is effective. Cephalosporins or broad-spectrum macrolides such as erythromycin may be prescribed if resistant organisms are known to be in the community. Remember that the recommended treatment days are very necessary to ensure that the streptococci are eradicated completely. So compliance and monitoring, making sure that the parents understood the importance of completing the full prescribed days of therapy, because if not, the child may develop a hypersensitivity or autoimmune reaction to streptococcus. As what I've said earlier, it's rheumatic fever or glomerulonephritis. Second, measures for rest, relief of throat pain, and maintaining hydration are also important. These are actually the same actions for a common cold. Retropharyngeal abscess are infected lymph nodes that drain the nasopharynx located just behind the posterior pharynx wall. It is caused also by group A beta-hemolytic streptococcus. Since these nodes disappear by the preschool to school age period, the problem is limited to young children or young infants. Typically, these children have an upper respiratory tract infection for a few days, and suddenly they develop the following symptoms listed in the slide. For management, because the most common cause of retropharyngeal abscess is group A beta-hemolytic streptococcus, benzathine pen-G or pen-V is effective. It is also important to suction to remove secretions. These secretions are results of their poor swallowing. Be careful not to touch the suction catheter to the posterior pharynx because this might rupture the abscess, possibly leading to aspiration of the abscess contents. It's also important to position side-lying to allow difficult to swallow mouth secretions to drain forward. Limiting oral intake to fluids is also important because hard foods could rupture abscess. Although some postpharyngeal abscesses resolve on their own, some need to be incised by a surgeon to promote drainage. Tonsillitis is infection and inflammation of the palatine tonsils. It's a lymphoid tissue on the sides of the pharynx, and these tonsils filter pathogenic organisms from the head and neck area. Adenitis is the infection of the adenoid or pharyngeal tonsils. All of the tonsils, referred to collectively as Waldeyer's ring as seen in the photo, are easily infected because of the bacteria that pass through or are screened through them with lymph. So again, the palatine are on the sides of the pharynx, adenoid nasopharynx, tubal tonsils at the entrance of the eustachian tube, and the lingual tonsils at the base of the tongue. With tonsillitis, the following assessment findings are seen. Its infection presents with all of the symptoms similar to severe pharyngitis. So basically, the management is the same as listed in the slide. Tonsillectomy is the surgical removal of the palatine tonsils. Adenoidectomy is the removal of the pharyngeal tonsils. Tonsillectomy is not always recommended. It is indicated if one of the three are present. One is recurrent tonsillitis. Second is if there is already an abscess. Third, it is recommended if there's already an airway or esophageal obstruction because of the tonsillitis. Pre-op management. It's important for nurses to make pre-operative preparation that is age-appropriate. You can explain to them in single terms or in simple terms what is about to be done. Also important to obtain baseline bleeding and clotting times. This will serve as a basis because after tonsillectomy, hemorrhage is the most common complication. Check also for any loose teeth, as these are young children or children who might have loose teeth and a risk for aspiration during surgery. Post-op management, position on side or on abdomen to help drain secretions. Avoid suctioning, coughing, gargles if possible because these activities could harm or damage the suture. Third, provide ice collar or analgesics for pain. The ice collar will also cause vasoconstriction, preventing edema. Fourth is observe for hemorrhage. Again, it is the most common complication. A child who frequently swallows would mean that there is hemorrhage. Also, there could be increased pulse, vomiting, and vomiting of bright red blood. But take note that an old dried blood or a pink-tinged emesis is normal. These are signs that the suture or the site is healing. Also, offer clear, cool, non-citrus, and non-red fluids when awake and alert. Giving these fluids can help you assess if there is bleeding. Sinusitis is infection and inflammation of the sinus cavities. What are sinuses? They are open areas of the skull. So when they become infected, why are they included in the upper respiratory tract infections? Mainly because sinuses produce mucus which drain directly into the nasal cavity. This infection is rare in children under 6 years of age because frontal sinuses, as seen in the photo, which is also the common site of infection, do not develop until that age. It is also an infection that is either primary or secondary, caused by different bacteria, such as Streptococcus, Staphylococcus, or H. influenza organisms, which spread from the nasal cavity. Assessment findings include fever, purulent nasal discharge, headache, tenderness over affected sinus, and epistaxis. When you palpate sinuses, it is important to assess for tenderness. This is very necessary in order to delineate sinusitis from other types of respiratory tract infections in the upper airway. Treatment: antipyretic for fever, analgesics for pain, nose drops to shrink nasal congestion, warm compress to sinus area for drainage and relieving pain, and antibiotics for specific organism involved. Basically, these are the same or similar to the other treatment regimens of the upper respiratory tract infections. If there would be serious complications because sinuses are open areas of the skull, if they invade the facial bone, it could be osteomyelitis, or if middle ear, it can cause otitis media. Chronic sinusitis can also occur. It can interfere with school and social interactions because of the constant pain, so it has to be managed very well. Laryngitis is the inflammation of the larynx, which may occur as a complication of pharyngitis or from excessive use of voice, such as when shouting or loud cheering. Because the larynx is the voice box, it results in a brassy, hoarse voice, or there is an ability to make an audible voice. For infants with laryngitis, you have to attempt to meet their needs before they start to cry. For older children, simply teach them to not speak. You can provide with a paper and pencil for communication. You can offer them also sips of warm or cold fluid, whichever they feel is best. This is for relief of annoying tickling sensation. But the most effective measure, however, is for the child to rest the voice for at least 24 hours. This is enough until inflammation subsides. Croup is inflammation of the larynx, trachea, and major bronchi, which is one of the most frightening diseases of early childhood for both parents and children. It occurs common between 6 months and 3 years of age and usually preceded by the para-influenza virus infection. Croup itself is not the infection. Attacks occur mostly at night, and again, onset is sudden and preceded by the mild upper respiratory infection. Assessment findings. Usually, the attack occurs at night. There are prior symptoms of mild respiratory tract infection, which is the para-influenza virus. The child is febrile and skill is cool. But if with fever, it's only mildly elevated. There is inspiratory stridor, there's hoarseness of the voice, there's a barking cough, there's anxiety, and there are retractions. These suggests extreme respiratory distress. As shown in the photo, the diagnostics reveal the stipple sign and subglottic narrowing. This means that there is laryngeal, tracheal, and major bronchi inflammation. Management. One emergency method of relieving croup symptoms is for a parent to do this at home. First, take child into the bathroom, close the door, turn hot water, and sit on the steamy bathroom floor. The steam or the warm heat will provide vasodilation, which will then cause dilation of the bronchioles. After spasm subsides, provide cool mist with a vaporizer. Provide also clear fluids. Keep child calm and quiet. Assure parents that this is self-limiting. But if the laryngeal spasm does not subside after this emergency intervention, child should be taken to the emergency room right away. In the hospital, a cool, moist air with corticosteroids will be given, such as dexamethasone or racemic epi by nebulizer. These will immediately relieve the bronchospasm. Start IV therapy also to keep the child well hydrated. Epiglottitis is the inflammation of the epiglottis. It's the flap of tissue that covers the opening to the larynx to keep out food and fluid during swallowing. Although rare, it is an emergency because the swollen epiglottis cannot rise and allow the airway to open. This causes reduction in airway diameter, which leads to sudden respiratory arrest. It commonly affects children between 2 to 7 years old. It can also be either from a bacterial or a viral origin. Symptoms begin as those of a mild upper respiratory tract infection, and then after 1 to 2 days, as inflammation spreads to the epiglottis, the child suddenly develops stridor, dysphagia, cough, hoarseness of the voice, high fever, very sore throat, and drooling. They may sit upright, the head forward, and jaw thrust is out. Laboratory findings show leukocytosis, and diagnostic tests would reveal the enlarged epiglottis. If a child's gag reflex is stimulated with a tongue blade, the epiglottis can be seen to rise in the back of the throat as a cherry red structure, which is so edematous. However, the gagging procedure causes complete obstruction of the glottis since it is swollen and it shuts off the ability of the child to inhale. Therefore, it is very important that in children with symptoms of epiglottitis, such as dysphagia, stridor, cough, fever, hoarseness, you should never attempt to visualize the glottis directly, unless an artificial airway such as tracheostomy or intubation is readily available. This is because it can completely obstruct. As a way to manage epiglottitis, one is to provide moist air through mist tent. This can reduce epiglottis inflammation. Second is to administer oxygen as needed, if with cyanosis. Third is to give IV antibiotics such as cefotaxime. After antibiotic therapy, the inflammation begins to recede rapidly, but still, the antibiotic must be continued 7 to 10 days. The siblings of this child diagnosed with epiglottitis can also be prescribed prophylactic antibiotic therapy. This is to prevent them from having the same infection. Fourth is to maintain hydration through IV fluids, especially because these children have difficulty swallowing. And anticipate also the need for tracheostomy or ET intubation to prevent total airway obstruction. These artificial airways may be removed by 12 to 24 hours after antibiotic therapy, since the swelling should have been reduced so much that the artificial airway is not needed anymore. Next are the lower respiratory tract infections. Influenza is the inflammation and infection of the major airways caused by the orthomyxovirus influenza types A, B, or C. Symptoms are cough, fever, fatigue, aching pains, sore throat, vomiting, or diarrhea. It is usually contagious on the day before symptoms appear and until about the next 5 days. It can be prevented by yearly influenza vaccine. Because influenza mutates yearly, vaccine is specific for only that year and must be re-administered yearly. Antipyretics such as acetaminophen or Tylenol can control the fever in influenza. Antivirals such as oseltamivir or Tamiflu can also be given to halt viral proliferation. It can be taken by children over 1 year of age, especially within the first 48 hours symptoms have appeared. These can hasten the severity or hasten the progress of disease and lessen the severity of the symptoms. Although most children recover, influenza can also lead to bronchitis or pneumonia. Bronchitis is the inflammation of the major bronchi and trachea. It commonly affects preschool and school-age children. Causative agents include several viruses and bacteria. For the assessment findings, symptoms may usually last for a week, with full recovery sometimes taking as long as 2 weeks. They have a mild upper respiratory tract infection for about 1 to 2 days, then the infection progresses downward. For younger children, they have fever and dry, hacking, non-productive cough. But in older children, cough is usually hoarse and mildly productive. On auscultation, rhonchi and coarse crackles can be heard. This suggests lung secretions. Chest radiograph will also reveal diffuse alveolar hyperinflation and some markings at the hilus of the lung. Management. Therapy is aimed at relieving respiratory symptoms, reducing fever, and maintaining adequate hydration. So this is similar to the other interventions for respiratory tract infections. Antibiotic is prescribed only if there is bacterial infection. Again, to differentiate viral from bacterial, bacterial infections are usually more severe. Bacterial infections usually cause higher fever, and also the secretions are more thick, viscous, and the color is greenish or yellowish compared to the whitish in viral infections. Third, if mucus is viscid, an expectorant is important to help the child raise sputum through coughing. So giving of antitussive drugs or cough syrups to suppress cough are contraindicated. Bronchiolitis is the inflammation of the fine bronchioles and small bronchi, which is common until 2 years of age. The peak incidence is 6 months. Many children who develop asthma later in life have numerous instances of bronchiolitis during their first year of life. Viruses are the usual pathogens most responsible for this illness. Assessment findings: typically, infants have 1 or 2 days of upper respiratory tract infection. Then, they develop nasal flaring, retractions on inspiration, and increased RR. This means that the infection has descended downward. They may have mild fever, leukocytosis, and increased ESR. The different levels of the blood tests and the fever would indicate also the amount of bronchial inflammation present. Third, most infants develop alveolar hyperinflation and can cause wheezing. This means that with the accumulating mucus and inflammation in the bronchioles, air enters more easily than it leaves the inflamed and narrowed bronchioles. Fourth, tachycardia and cyanosis may also develop. This is from hypoxia. For the tests, chest radiograph may show infiltrates in the lungs caused by the infection or alveolar collapse. Pulse oximetry also shows low O2 sat, and a throat culture will specifically identify the causative organism. Management. For less severe symptoms, the child can be managed inside the homes. Antipyretics for fever, adequate hydration, especially when feeding is a problem because infants tire easily and they cannot finish feeds. Also, parents must maintain a watchful eye for progression to more serious illness. If symptoms are severe, the child requires hospitalization. In the hospital, humidified oxygen must be given. So we have discussed previously different oxygen therapies. These can counteract hypoxemia. IV hydration is important to keep respiratory membranes moist, and medications through nebulization such as bronchodilators, epinephrine, and anti-inflammatory drugs given parenterally can also help open airway, relieve bronchospasm, and improve the ventilation and gas exchange. Some children would also need ventilatory assistance so they can achieve adequate ventilation. So this is through intubation. Pneumonia is the infection and inflammation of the lung alveoli. It is the functioning unit of our lungs, caused by bacteria or virus. There are 2 types. Hospital-acquired pneumonia are commonly caused by pneumococcal and streptococcal bacteria, while community-acquired pneumonia from chlamydia and viral. It's the most common cause of death in infants 48 hours old and below. And now, as a current issue, COVID-19 virus causes pneumonia, which is also the leading cause of death among these patients. Assessment findings: fatigue, anxious, shallow respirations, productive and harsh cough, fever, decreased breath sounds, and growls. Adequate ventilation is very important. Humidified oxygen may be necessary in order to alleviate labored breathing and prevent further hypoxemia. Second is to remove secretions. Chest physiotherapy may be helpful so that mucus will move and prevent obstruction. In older children, they may be encouraged to cough so that secretions do not pool and become further infected. Third is good oral hygiene. This will prevent further infection, and this will also help improve the child's appetite This is to establish good nutrition too. Fourth is adequate rest and relief of pain. Allow the child to sleep well, provide relaxation techniques, or you can also give simple analgesics. Administer antibiotics. Sometimes it is given for a span of 7 to 14 days. You can give ampicillin, cephalosporins, or for penicillin-resistant organisms, amoxicillin clavulanate or augmentin. 6 is to prevent transmission. Pneumonia is highly contagious, so important to consider universal precautions, such as hand washing, wearing of PPEs, for example. 7 is control fever and chills. You can give antipyretics and provide hydration as well. Tuberculosis is a highly contagious pulmonary disease caused by Mycobacterium tuberculosis. Mode of transmission is through inhalation of droplet with an incubation period of 2 to 10 weeks. When the disease becomes active, meaning signs and symptoms arise, 75% of the cases are pulmonary. The rest are outside the respiratory system. When M. tuberculosis invades a child's lung, there is primary inflammation. The child will then develop the local and systemic symptoms. First, leukocytes and lymphocytes will attack the TB and wall off the primary infection. This wall calcifies and confines the TB permanently. This development is the usual form in children. If with poor health or the child does not have an adequate calcium intake to confine the TB, this may spread to bones and joints, lymph nodes, kidneys, and subarachnoid space as miliary TB. Diagnostic tests: the Man-2 tuberculin skin test or the PPD. In this test, you give 5 units of protein derivative vaccine intradermal on the lower arm. Inspect it within 72 hours. It is positive if there is 5 to 10 or 5 to 15 millimeters of reddened induration, meaning the patient was exposed to TB or the patient developed antibodies. Second is through chest radiograph. Results would reveal that there is cloudiness and calcification in the inflamed area. Third is sputum exam. This is the confirmatory test because in the sputum there is the live bacilli. It must be taken deep cough and early morning. The vaccine is Bacille Calmette Guerin or BCG. It is given at birth 0.05 ml intradermal into the deltoid area. It's the part of complete vaccination in the Expanded Program of Immunization or EPI of the DOH here in the Philippines. BCG is a vaccine for extrapulmonary TB. DOTS treatment, on the other hand, according to WHO, is the most cost-effective way to stop the spread of TB, especially in communities with a high incidence. It is the best curative method for TB. It involves medications. In the Philippines, we use these 5 medications in a span of 6 to 9 or 9 to 12 months of continuous daily treatment. The first 4 drugs are taken orally. The 5th drug is through parenteral injection. Asthma is immediate hypersensitivity or a type 1 response where smooth muscle constriction and mast cells release histamine, leukotrienes, and prostaglandins, which results in diffuse obstructive and restrictive airway disease. It tends to occur initially before 5 years of age, although in these early years it may be diagnosed as frequent occurrences of bronchiolitis rather than asthma. So later on we will see the similarities and difference of bronchiolitis from asthma. Often, asthma is caused by an allergic reaction to allergens. These allergens include pollens, molds, house dust, certain foods, cold air, irritating odors such as smog, cigarette smoke, changing of seasons, or even taking of certain drugs such as aspirin. It could be intermittent, seasonal, which means there are periods the child is symptoms free, and chronic, or it is year round with continuous symptoms. The immunologic or allergic reaction in asthma primarily affects the small airways and involves the three separate processes. First is bronchospasm, the constriction of smooth muscles of the bronchi and bronchioles. Second is inflammation of the bronchial mucosa. It's the edema of the membrane wall. And third, increased bronchial secretions, the accumulation of tenacious mucus. All these three processes act to reduce the size of the airway lumen, leading to acute respiratory distress. The first one, bronchospasm or bronchial constriction, is from the parasympathetic or the cholinergic system, as it initiates smooth muscle constriction, while 2 and 3, the inflammation and mucus production, from mast cell activation to release histamine, leukotrienes, and prostaglandins. All these three processes are also seen in bronchiolitis. It's the same. What's the difference? Asthma leads to these three processes because of an allergen, while bronchiolitis leads to these three processes because of pathogens. The word asthma is derived from the Greek word for panting. It's a description of the child's distress. So, what signs of distress can be seen? First, asthma may begin with a dry cough. The child may inhale normally or with little difficulty. This bronchoconstriction is usually evident after exposure to allergen. Dyspnea and wheezing in all lung fields. As difficulty exhaling develops, cyanosis may also occur. It is very difficult to force air through a narrowed lumen of the inflamed bronchioles that is filled with mucus. So wheezing, especially when heard on inspiration, would reveal extreme difficulty. Third, progresses to coughing up mucus that is generally copious and may contain white casts. The white casts bear the shape of the bronchi from which it was dislodged. Fourth, expiration is longer than inspiration, which is the opposite of normal. During an attack, the child must work hard to exhale. That's the reason why. Fifth, air-filled lungs are hyperresonant to percussion. It is loud and hollow noise than usual. 6. Possibly with retractions and use of intercostal accessory muscles. The chest wall is drawn inward in order to achieve full breaths. For the test results, there is high eosinophil count, low O2 sat, decreased ability to exhale in a peak flow meter. It's a device to measure breath, especially in asthma, and low PCO2 level. Therapy for children with asthma involves planning for 3 goals of all allergic disorders. One is avoidance of the allergen by environmental control. Taking history is necessary to be able to identify allergen, therefore can control it. Second is skin testing and hyposensitization. The sensitization aims to make the allergic patient's immune system tolerant to the allergen. Third is relief of symptoms by several pharmacologic drugs, corticosteroids or fluticasone as anti-inflammatory drugs, bronchodilators, albuterol or terbutaline, cromolyn sodium. It's a mast cell stabilizer given through nebulizer or metered dose inhaler. It's a good drug for prophylaxis of asthma. Leukotriene receptor antagonist or Montelukast, it's also a drug for prophylaxis against asthma. Parents need good instructions to be able to continue to address all these three concerns over an extended period of time. Under ordinary circumstances, an asthma attack responds readily to the first-line therapy mentioned in the previous slide. But when children suddenly fail to respond and an attack continues to be severe, they are in status asthmaticus. A child in this state is in acute respiratory distress. This is an extreme emergency as a child may die of heart failure because of exhaustion, atelectasis, and respiratory acidosis from bronchial plugging. Continue first-line pharmacologic agents, give the drugs, but start oxygen therapy right away. Aspiration of foreign objects. This is the inhalation of a foreign object into the airway, which occurs most frequently among the curious infants and toddlers. Management is immediate removal of the foreign object. Immediate reaction is choking and a hard, forceful coughing. This usually dislods the object, but if the airway is so obstructed, coughing may be impossible, there may be no sound with cough, or there are signs of increased respiratory difficulty like stridor. Some intervention is essential. For the upper airway, subdiaphragmatic abdominal thrusts for older children, and back blows and chest thrusts for infants. For lower airway, bronchoscopy. This photo shows subdiaphragmatic abdominal thrust being done on a school-aged child. This is for upper airway obstruction in older children. This is done same for adults. This photo is for upper airway obstruction among infants. Picture A shows back blows and B, chest thrusts to relieve completely the foreign body in the infant. Do not do the item 1, which is the subdiaphragmatic thrust to an infant because of the risk of rupturing liver. The third is through the use of bronchoscopy for lower airway obstruction. It's the standard method to remove the aspirated foreign body. Usually, you put the child in conscious sedation to remove the aspirated object. It can be inserted via the nose or the mouth, and then the doctor would visualize the airway or the tract either directly through the bronchoscope or through a monitor. After removal of the foreign object, the child should be on NPO. It's important to check for the gag reflex and then can give cool fluid to soothe and reduce soreness. Also, maintain the child in a cool, moist environment, and it is also important to treat secondary infection. Cystic fibrosis is an autosomal recessive disorder caused by the abnormality of a long arm of chromosome 7. Although this disease can be fatal early in life, as many as 50% of children now live to be more than 30 years of age. Generally, it's characterized by dysfunction of the exocrine mucus-producing glands. Associated problems: pancreas, lungs, sweat glands, and reproductive system. In pregnancy, this disorder can be detected through chorionic villi sampling or amniocentesis. Among newborns, cystic fibrosis can be screened at birth by a heel puncture blood sample and then sent to the laboratory to test. Let us now discuss the specifics of the organs involved or the associated problems involved. First is the pancreas involvement. The enzymes of the pancreas, particularly lipase, trypsin, and amylase, these enzymes are responsible for metabolism and digestion of food. These enzymes become so thickened that they plug the ducts that flow into the small intestine, particularly the duodenum. Now, without these pancreatic enzymes, as is in a child with cystic fibrosis, the children cannot therefore digest fats because of lack of amylase, protein because of lack of trypsin, and sugars or carbs because of lack of amylase. What are the findings? Stools become large, bulky, and greasy, as in steatorrhea, and it has a foul odor because intestinal flora increases due to undigested food. When combined now with fat in the stool, this gives an extremely foul odor, just like a cat's stool. Second is the abdomen becomes protuberant. It is because of the build-up of feces in the intestines. And third, there are signs of malnutrition and unabsorption of the fat-soluble vitamins A, D, E, and K, such as emaciated extremities and loose, flabby folds of skin on buttocks. This is because children are benefiting from only about 50% of the food they ingest because of the lack of pancreatic enzymes. Second is the lung involvement. This is the most crucial and the most serious one. Lungs develop thickened mucus pools within the bronchioles. This results in several lung infections, emphysema, bronchiectasis, respiratory acidosis, and atelectasis. This is actually a chronic problem, and as signs of chronic lung involvement, the child's fingers become clubbed because of the inadequate peripheral tissue perfusion. There's also changes in the anterior and posterior diameter of the chest. It becomes enlarged. Third is the sweat gland involvement. Although sweat glands do not appear to be changed in structure with cystic fibrosis, the electrolyte composition of the perspiration changes. The level of chlorine to sodium is increased 2 to 5 times above normal. In this case, there is salty taste in the skin. The mutant CFTR channel causes sticky mucus to build up on the outside of the cell, as shown in the photo. CFTR stands for cystic fibrosis transmembrane conductance regulator. Reproductive function involvement. Among boys, they have persistent plugging and blocking of the vas deferens because of the tenacious or the thick seminal fluid. This causes sterility. Girls may have thick cervical secretions where sperm penetration becomes a problem. This causes infertility among them. Artificial insemination or IVF can be accomplished if the couple desires to become pregnant. Diagnostic tests. A sweat test can be done to check for the chlorine level. If it is more than 60 mg per liter, it is a diagnostic for cystic fibrosis. Duodenal analysis through passing an NGT into the small intestine or endoscopy. Then, the test is done to aspirate secretions. The contents are then checked, which reveals decrease to absent trypsin. There are 3 pancreatic enzymes, but assessing the trypsin is enough. It's the easiest pancreatic enzyme to assay. Stool analysis. It is collected and analyzed for fat content, and also the lack of trypsin can also be detected there. Although, looking at the appearance of the stool itself, a large greasy appearance is all that is necessary. And lastly, pulmonary testing. This is the one requiring long-term treatment and management for cystic fibrosis patients. That is the reason why, even if cystic fibrosis involves lots of organs, it's a multi-system condition. Cystic fibrosis is regarded as a respiratory disorder among children. A chest radiograph shows pockets of emphysema and pneumonia, again because of the thickened lung secretions. Pulmonary function tests are abnormal, and ABG shows respiratory acidosis. Management. Cystic fibrosis management is needed, and the parents or the healthcare workers should provide appropriate long-term therapy and support. For items 1 and 2, these focuses on the pancreas involvement. So you give pancreatic enzymes, provide high calorie, high protein, and normal fat diet. The items 3 to 7 are interventions for lung involvement. So giving of antibiotics for pneumonia and other infections, expectorants and mucolytics for the increased and thickened mucus secretions. Avoid cough suppressants because the thickened mucus secretions must be expelled. Encourage breathing exercises and perform CPT as well. Aerosol treatments such as nebulizers, intermittent positive pressure breathing, or mist stent may also be given. For the sweat gland involvement, you need to add salt to all meals or give salty snacks, especially during the summer when there is more heat and more sweat. And number 9 is for the reproductive function. Recommend possible assisted reproductive techniques because of the risk of infertility and sterility.